Welcome back to the great adventure, Pediatric Pulmonary Physiology. So today we have the final episode in our series of 30. This is High Altitude Physiology, Part 4. And this is the great adventure, Pediatric Pulmonary Physiology. And we are on the last of our series today. We want to approach this like with the enthusiasm of a child in a candy shop. So today we're going to talk about pre-existing lung disease at altitude. We often get asked to assess or advise our children with lung disease who want to go to altitude. Children at high altitude, adaptation, this is high altitude populations, and finally, chronic mountain sickness. And recall that most physiologic studies measure altitude in meters. We're more familiar with altitude in feet. So to convert meters to feet, multiply by 3.3, and that will give you an approximate value. So what about pre-existing lung disease at high altitude? We are frequently asked to counsel our patients who travel to high altitude. Increasing numbers of people travel to high altitude for work, adventure, holidays, expeditions, skiing, and religious pilgrimages. Physicians are asked to counsel patients on the risk of their planned trips, and this is complicated when pre-existing medical conditions might worsen at high altitude. Unfortunately, there are few studies to guide such advice. Pre-existing lung disease does not seem to affect the incidence of acute mountain sickness, high-altitude cerebral edema, and high-altitude pulmonary edema. Questions we need to ask: will the underlying condition get worse at high altitude? Will the underlying condition predispose the patient to acute mountain sickness, high-altitude cerebral edema, or high-altitude pulmonary edema? Is the patient at risk for developing severe symptomatic hypoxia at high altitude, and can we manage this in that environment? Will the underlying condition predispose to poor exercise tolerance at high altitude? What is the availability of medical resources in the area of planned travel? Many travel to resort areas where medical care is often readily available. However, some travel to remote areas where medical care and timely evacuation might be difficult or unavailable. Patients with severe disorders should avoid remote areas, trekking, etc. The patient's underlying condition obviously should be stable prior to travel to high altitude. So let's talk about a few specifics. Asthma. A variety of factors affect asthma control at high altitude. Factors that may improve control are low air density, increased sympathetic activity, and decreased dust mites at high altitude. Factors that may worsen control are hypoxia, hypocapnia, and cold air. Predicting which has the greatest influence on an individual can be difficult. Well-controlled asthma patients tolerate high-altitude travel without much problem. Severe asthma or following a recent exacerbation should avoid travel at high altitude. One should not let inhalers freeze or get too hot. One should take extra inhalers and oral prednisone, especially if in a remote area. Remember that puffs delivered from inhalers are decreased above 3,000 meters, which is about 10,000 feet elevation. Chronic obstructive pulmonary disease. The challenges at high altitude include hypoxia, increased ventilatory requirements, and increased pulmonary vascular resistance. COPD patients on commercial air flights with FEV1 1 to 1.5 liters have a PO2 less than 50 torr, and it is even lower with exercise such as walking. Supplemental oxygen may be required for severe COPD, and one should avoid altitude altogether if a COPD patient is hypercapnic, has an FEV1 less than 1 liter, or has pulmonary hypertension. This slide shows altitude. So aircraft often travel well above 12,000 meters, but cabins are pressurized to approximately 2,500 meters or 6,000 to 8,000 feet elevation. So here's what happens to pulmonary artery pressure when COPD patients or others fly to altitude. So this is altitude in feet up to 8,000. And you can see that normal subjects without COPD have only a slight rise in pulmonary artery pressure. But patients with COPD, first of all, start with a higher pulmonary artery pressure, and it can rise considerably, well above the normal slope with exposure to altitude. Interstitial lung disease. So PO2 falls to less than 50 at 2,340 meters during rest, and it's even lower during mild exertion, such as walking. Reduced pulmonary compliance increases work of breathing, especially with hypoxic ventilatory response. Some interstitial lung disease patients may have pulmonary hypertension, and a TLC, total lung capacity, less than 50% predicted, or requirement for supplemental oxygen. Patients with those should probably avoid travel to high altitude altogether. Cystic fibrosis, 2,000 to 3,000 meters altitude, which is 6,600 to 9,900 feet, is associated with significant hypoxia, worse with severe disease or exercise. Severe disease, defined as an FEV1 less than 30% predicted, should avoid high altitude travel. Less severe patients often do well, but they need to maintain their medications and their airway clearance. Supplemental oxygen is recommended for patients with FEV1 between 30 and 50% predicted normal. Ventilatory control disorders. We have several congenital central hypoventilation syndrome, or CCHS, patients who have had trouble at altitude and required descent, but unfortunately there are few studies, if any, to guide us. These patients do not mount a ventilatory response to hypoxia, so they can become quite hypoxic and hypercapnic, yet because of both absent objective and subjective response to hypoxia and hypercapnia, it often is not known that they are experiencing hypoxia. If travel is necessary, one needs to increase ventilatory support and closely monitor gas exchange. In general, it's probably best that these patients be ventilated full-time. Certainly living at high altitude may require full-time ventilatory support, even if they could be weaned from ventilatory support during wakefulness at sea level. Altitude hypoxia causes pulmonary vasoconstriction and increased cardiac output, which increases pulmonary artery pressure. So they are probably predisposed to high altitude pulmonary edema. Patients with severe pulmonary hypertension, especially if requiring continuous IV vasodilator therapy, should avoid high altitude travel. And pulmonary hypertension is the lung disorder with the general contraindication to high altitude travel. So pre-existing lung disease, as a general recommendation, patients with mild lung disease, which is in good control, may tolerate high altitude travel. However, there is a higher risk of hypoxia. Some patients with severe lung disease should not travel to high altitude, and some patients may require supplemental oxygen. Extra precautions are required for travel to remote locations. High altitude simulation test. High altitude simulation test, sometimes called the fit to fly test, can assess the gas exchange after an acute change in PiO2 at a simulated high altitude. The gold standard for this test is actually using a hypobaric chamber to create hypobaric hypoxia, which is in fact what happens at altitude. However, very few facilities have hypobaric chambers, so most people perform high altitude simulation studies by simulating the altitude using decreased FiO2, fractional inspired oxygen, at sea level. And this just gives you a chart of altitude from 0 to 12,000 feet, the PiO2 associated with each of those altitudes, and the fraction of inspired oxygen that you would need to use at sea level to simulate these altitudes. So notice an altitude of 10,000 feet, for example, is equivalent to breathing 14% oxygen, 12,000 feet, 12%. The Children's Hospital Los Angeles high altitude simulation protocol is generally testing, first of all, 6,000 to 8,000 feet, and the reason is that's where commercially available aircraft are pressurized, and very few of our patients are going to elevations higher than 8,000 feet. So our subjects breathe room air with a fraction of inspired oxygen 21% for 15 minutes. That's the control, sea level. Then an FiO2 of 17%, which simulates an altitude of 6,000 feet. And then an FiO2 of 15%, which simulates an altitude of 8,000 feet for 15 minutes. We, as a default, add supplemental oxygen if the oxygen saturation falls below the normal oxygen saturation predicted for that altitude. However, the ordering physician may specify a minimal saturation above the normal predicted for age. For example, many children with pulmonary hypertension, one would want the saturation of hemoglobin to be at least 95%, even though normal might be well below that. So these are normal values for O2 saturation at high altitude. So you can see that at 10,000 feet, it's normal to have saturations as low as 83%. 8,000 feet, it's normal to have saturations as low as 89%. So it turns out that the saturation at sea level does not predict saturation at a simulated altitude of 8,000 feet. Our total oxygen saturation values for a high altitude simulation test at 8,000 feet, which is an FiO2 of 0.15 at sea level. A saturation of 90% did not discriminate controls from chronic lung disease of infancy, but a saturation of 85% did discriminate controls from infancy. Normal saturation at 8,000 feet, again, is greater than or equal to 89%. So one cannot really use arterial oxygen saturation of a hemoglobin at sea level to predict somebody's response at altitude. So what does a high altitude simulation study tell you? It tells you the adequacy of gas exchange at selected simulated high altitudes while awake. It tells us the hypoxia and effect of supplemental oxygen, and it tells us if there's any hypoventilation at elevation when hypoxic. What a high altitude simulation test does not tell you is susceptibility for acute mountain sickness, high altitude pulmonary edema, or high altitude cerebral edema. It also does not predict the long-term effects of hypoxia, since the test is only about an hour in total time. So just emphasize, a high altitude simulation test does not predict whether somebody is susceptible to acute mountain sickness, high altitude pulmonary edema, or high altitude cerebral edema. So what about children at high altitude? Are there any special considerations? So heat and cold in children, child surface to weight ratio is increased. So they lose heat faster in cold and gain heat faster when it's warm. There's less subcutaneous fat and underdeveloped shivering. So heat is lost through the head. Children can become hypothermic more rapidly in cold. And eye protection on glaciers or snow should be used due to the increased reflection of sunlight. Hypoxia depresses ventilation in neonates. At sea level, the hypoxic ventilatory response matures to an adult pattern in the first few weeks of life. At altitude, at around 8,000 feet, infants still have frequent periodic breathing and apnea at 3 months. The effect on arterial oxygen saturation and hemoglobin during sleep varies quite a bit by population, the altitude you're at, and age. This just shows some examples of residents of high altitude from different places. So this is oxygen saturation during sleep, and you can see this is after acute arrival at altitude, less than 24 to 48 hours, 1 week, 1 month, 2 months, 3 months, 4 months. So you can see that going to Denver, for example, about a mile high, 5,280 feet, is associated with a slight decrease in saturation, but it doesn't change. Acutely going to Lhasa in Tibet is associated with a significant drop in saturation, and it remains, it does not drop. Residents of Leadville, Colorado, a bit over 10,000 feet, 3,100 meters, actually have an initial drop, but this improves with time after about 2 months and then remains relatively stable, although still low, below 88%. And finally, the Lhasa Han Chinese population has not been at this elevation as long as Tibetans, has a more dramatic fall in saturation, which remains over the whole 4-month period. So there are some differences in infant saturation, oxygen saturation, and hemoglobin during sleep at high altitude, depending on where you're from and your racial ethnic origin. Toddlers aged 3 to 36 months were studied at Denver and at 3,109 meters. Again, that's a bit over 10,000 feet. After 24 hours at altitude, children showed tachypnea, relative hypoxia, hypocarbia, and reduced cerebral tissue oxygenation using near-infrared spectroscopy. The changes were similar to adults. Also, the incidence of acute mountain sickness is similar to adults. Children aged 6 to 13 years were studied during a trek to Nepal at 3,500 meters or 11,550 feet. I have to pause here for a moment and wonder why anyone would take children on a trek to that elevation. But nevertheless, Over the course of the trek, children showed small increases in respiratory rate, increases in heart rate by about 24 beats per minute, daytime decreases in saturation by 9%, sleeping decreases in saturation by 11%, and decrease in CO2 by 7 torr compared to when they were at sea level. Forced vital capacity and FEV1 remain within 7% of sea level values. Acute mountain sickness in children, there is a similar incidence of acute mountain sickness at 3,090 meters, or about 10,200 feet, which is about 19% in children and 24% in adults. There are no reports of high altitude cerebral edema in children. High altitude pulmonary edema has an equal incidence in children, about 1.5%, and in adults, about 1.3%. The treatment is the same for children, which is descent. Pharmacologic treatment has not been studied in children, but is presumed to have similar efficacy as it does in adults. But again, the best primary treatment is descent. Children at high altitude, in general, risk probably outweigh benefits for infants going to high altitude. Children less than 2 years of age should not sleep at altitudes greater than 2,000 meters or 6,600 feet. It's the altitude at which you sleep that seems to be the important parameter. Children 2 to 10 years should not sleep at altitudes greater than 3,000 meters, which is about 10,000 feet. And children greater than 6 who can verbalize symptoms suggesting acute mountain sickness can probably safely sleep as high as 3,500 meters or 11,550 feet. High altitude populations, their adaptation, populations who live there for years or centuries, or in some cases, populations that have been there for even millennia, how do they adapt to living at high altitude? Remember, acclimatization is the process where lowland humans and animals adapt to reduce PiO2, and it refers to changes viewed as beneficial. It tends to reduce the fall in PO2 in tissues. Adaptation is the characteristics of people born and raised at high altitude, and it's not clear if this is genetic or due to the influence of hypoxia on growth, and we're not going to answer that question. You've seen this before. Acclimatization occurs up to uh, several months, perhaps 3 years. Adaptation can occur up to 30,000 years. Some of the populations in the Tibet Plateau have been there for 30,000 years, which presumably allows for a fair amount of genetic changes, which would be beneficial to living at altitude. So briefly, the most important one that's seen after a long time at altitude is a decrease in the pulmonary hypoxic pressure response of pulmonary arteries. Hypoxic ventilatory response also decreases. So there are differences between different highland populations and between highlanders and lowlanders. These may be due to genetic differences selected over many generations as having survival advantages for life at high altitude. They may be due to being born and raised at high altitude. Some highland populations are known to have lived at high altitude for over 30,000 years, increasing their chance of adaptation. So most people experiencing physiologic changes residing at altitude greater than 3,000 meters or 9,900 feet. For sea level visitors, the highest acceptable altitude for permanent habitation is 46 to 4,900 meters. For native high altitude residents, the highest acceptable altitude for permanent habitation is about 5,800 to 6,000 meters or 19,000 to almost 20,000 feet. The highest permanent human habitation is La Rinconada in Peru. There are about 30,000 people who live there. It's at an elevation of 5,100 meters, which is about 16,000 feet. This is actually a picture of La Rinconada in Peru, and you can see again, elevation is 16,732 feet. So the World Health Organization estimates that there are millions of people living in altitude. This is data from 2004, but at that time, they estimated that about 89 million people lived at altitudes above 2,500 feet, that's meters, that's roughly 8,000 feet. About 25.9 million lived above 3,500 meters, that's about 11,500 feet. And about 5.4 million lived above 4,500 meters, which is in the range of 18,000, 19,000 feet. So in the Tibetan Plateau, it's an altitude of 3,600 to 4,900 meters, or 11,000, almost 12,000 feet to 16,000 feet. And Tibetan natives have lived there for over 30,000 years. Han Chinese immigrated more recently. In the South American Andes, plateaus are about 4,000 meters or 13,200 feet, and human habitation has been documented there for at least 12,000 years. The Ethiopian highlands are a little bit lower, 2,400 to 3,700 meters, or almost 8,000 feet to 12,000 feet, and human habitation has been documented there for greater than about 3,000 years. So one might predict that residents of the Tibetan plateaus might have the best adaptation because as a society or as a population, they've lived there the longest. So in terms of high altitude habitation, highlanders compared to lowlanders have a lower total minute ventilation at rest and exercise. Blunt and hypoxic ventilatory response, though this is less in Tibetans than in Andean highlanders. And despite lower minute ventilation, they have similar saturation and PO2 at rest. Highlanders compared to lowlanders have a P arterial O2, which is less reduced on exercise. There's slightly larger lungs and higher diffusing capacity. There's very little pulmonary artery pressure response to hypoxia in Tibetans, but this is not quite so true in Andean highlanders, and there are lower hemoglobin concentrations. Placenta growth, placenta weight is not greater, but birth weight is lower so that the placenta infant weight is higher. Villus vascularization is increased, the diffusion barrier is thinner, and these increase the membrane diffusing capacity for oxygen across the placenta at high altitude. Fetal growth at high altitude, after the first few weeks, fetal growth is normal until the last trimester. Last trimester growth slows, producing a lighter baby at term. The fetus at altitude is not hypoxic compared to sea level fetus, and increased uterine blood flow may restore normal oxygen delivery to the fetus despite hypoxemia. Birth weight at high altitude, birth weight is lower at high altitude. Birth weight of 3.5 kilograms in Lima, but 2.8 kilograms in Cerro de Pasco, which is 14,000 feet elevation. Andean infants at also about 14,000 feet had a delay in saturation stabilization at birth and lower APGAR scores. There was no difference in birth weight of babies, sorry, that should be 28 to 36 weeks gestation, but there was a decreased birth weight compared to 36 to 42 weeks gestation. The duration of time at altitude had more of an effect than the actual altitude. So there are a number of diseases that residents of high altitude can get. Chronic mountain sickness, which we'll talk about, high altitude pulmonary edema, chemodectoma, which is a benign tumor of the carotid body. There's a high incidence of patent ductus arteriosus at birth. There's a higher incidence of goiter, but this is due to low iodine in the soil at altitude, not necessarily due to hypoxia. There is a higher infant mortality, and there is a higher SIDS rate for infants living above 2,438 meters. And that's shown here. You can see that there were almost 400,000 infants in this study, 165 SIDS victims, and the incidence, SIDS per 1,000 live births, shown here, is lower if you live under 6,000 feet or 6 to 8,000 feet, but essentially double if you live at greater than 8,000 feet elevation. Childhood growth. So children living at high altitude, birth weight is lower and early growth is slower. Developmental milestones such as sitting and walking occur slightly later. Height and the adolescent growth spurt last by about 2 years, but growth does occur longer. Adult stature is often not achieved until age 22 years. Menarche and adrenarche are delayed by about 2 years at high altitude. Lung growth. In high altitude residents, there's a large chest circumference, a vital capacity, total lung capacity, peak expiratory flow rates, especially in adults, greater than 50. Infants have high thoracic compliance. Residual volume and RV-TLC ratio are increased 21 and 28% respectively, which may reduce breath by breath PCO2 oscillations. Vital capacity decreases with age faster than in sea level residents at altitude. High altitude residents also have increased lung growth associated with increased area available for gas exchange. So they have an increased diffusing capacity. Increased gas exchange can occur in as little as 2 years of hypoxia during important growth phases. Sherpas are less alkalotic due to a higher PCO2, but they have a more efficient oxygen transfer. This just shows oxygen saturation at altitude in three groups of individuals. So Tibetans in the solid circles, Andeans in the open circles, and Europeans who generally aren't going to very high altitude. But you can see, not surprisingly, that these all decrease, and there's a little bit of variation by these three groups. So ventilatory control in high altitude residents, they hypoventilate compared to lowlanders. PCO2 is slightly higher, so slightly less alkalotic. There's a lower hypoxic ventilatory response, especially response to chronic hypoxia. And this blunting of the hypoxic ventilatory response occurs over decades. But children living at high altitude have normal hypoxic ventilatory response, which becomes abnormal with age at altitude. This shows resting ventilation for Tibetans by age here. You can see there's quite a bit of variation. There's less variation among the Aymara population in the South American Andes. The hypoxic ventilatory response, again, there's a bit more variation among Tibetans than there is in the South American Andes population. The majority of people have relatively lower hypoxic ventilatory responses, as do the Andean subjects in general. Pulmonary circulation in high altitude residents, there's an elevated pulmonary artery pressure and elevated right ventricular pressure due to hypoxic pulmonary pressure response, which results in right ventricular hypertrophy. In children, muscularization of pulmonary arteries does not decrease or does so only partially. And in large and small pulmonary arteries show greater muscularization than sea level residents. This same sort of change was shown years ago in children with chronic hypoxia, for example, with chronic lung disease of infancy. In Tibetan high altitude residents, there is a decreased hypoxic pulmonary pressure response, decreased pulmonary artery pressure, and little rise in pulmonary artery pressure on exercise. They do not develop pulmonary artery structural changes. They have decreased right ventricular hypertrophy. There are increased branches to the coronary arteries, and there's increased nitric oxide in lung plasma and red blood cells. So differences between highland and lowland populations are due to the effects of hypoxia growth and or genetics. Growth in childhood is delayed but continues longer. There's a lower minute ventilation at rest and exercise with a lower hypoxic ventilatory response. Larger lungs, increased diffusing capacity, so oxygen transport is more efficient. There's also decreased hypoxic pressure response and less pulmonary hypertension. There's lower hemoglobin and high arterial oxygen saturation hemoglobin. And diseases in chronic highlanders include chronic mountain sickness, pulmonary hypertension, chemodectoma, which is a benign tumor of the peripheral chemoreceptor or carotid body, and decreased fertility and increased rates of sudden infant death syndrome. So what about chronic mountain sickness? So chronic mountain sickness is one of the diseases that can affect long-term high-altitude residents. It's characterized by excessive erythropoiesis, and that's defined as polycythemia with hemoglobin greater than 19 in females or greater than 21 in males, and sometimes with pulmonary hypertension. High-altitude pulmonary hypertension is distinguished slightly in that there's pulmonary hypertension but no erythropoiesis. This is an early description of this disorder, and the investigator writes, chronic mountain sickness is a clinical syndrome that occurs in native or long-term residents above 2,500 meters, 8,250 feet. It is characterized by excessive erythrocytosis, hemoglobin greater than 19 for females and greater than 21 for males, severe hypoxemia, and in some cases moderate or severe pulmonary hypertension, which may evolve into cor pulmonale, leading to congestive heart failure. The clinical picture of chronic mountain sickness gradually disappears after descending to low altitude, and it reappears on returning to the same high altitude. So symptoms include headache, dizziness, paresthesias, somnolence, fatigue, difficulty concentrating, and a loss of mental acuity. There's also irritability, depression, hallucinations can occur. Dyspnea on exertion is rare, interestingly. There's poor sleep quality and burning of the hands and feet. Clinical signs, cyanosis due to both hypoxia and increased hemoglobin, black lips and red wine mucosa, congested conjunctiva, digital clubbing, and peripheral edema. There's an elevated red blood cell count, hemoglobin, and hematocrit versus those high altitude dwellers who do not have chronic mountain sickness. Hemoglobin as high as 28 grams per deciliter has been described, and hematocrit as high as 80% or even 91% have been described. There's decreased arterial PO2, increased arterial PCO2, and decreased arterial oxygen saturation of hemoglobin compared to non-chronic mountain sickness individuals at the same altitude. And this is due in part to hypoventilation and an increase in the alveolar to arterial oxygen gradient. So prevention. The sure way to prevent is to descend to low altitude without return to high altitude. But this is not possible for some due to family or occupational concerns. One should avoid cigarette smoking, occupational hazards, and lung disease. And persons who are small for gestational age born at high altitude may have an increased risk of chronic mountain sickness. Treatment, as with other disorders at altitude, is descent to low altitude without a return to high altitude. This is a sure treatment for this disorder. However, this may not be possible for some due to family or occupational concerns. Bloodletting to reduce hemoglobin improves symptoms, gas exchange, and exercise performance. So there is a role for bloodletting in modern medicine. Respiratory stimulants, medroxyprogesterone acetate is a respiratory stimulant, decreased hemoglobin and improved oxygenation. It improves sleeping hypoxia, most importantly. Acetazolamide, carbonic anhydrase inhibitor, decreased hemoglobin and erythropoietin, increased nocturnal saturation by 5%, and the dose, as with for prevention or treatment of acute mountain sickness, for adults is 250 milligrams PO/BID. This is the severity scoring for chronic mountain sickness. You can say you can get 0 to 3 points for each of these parameters: breathlessness, sleep disturbance, cyanosis, vein dilatation, paresthesia, headache, tinnitus, and of course high hemoglobin. And you can see 0 to 5 is no chronic mountain sickness, 6 to 10 mild, 11 to 14 moderate, greater than 15 severe. So in summary, patients with mild pre-existing lung disease, which is in good control, may tolerate high altitude travel. However, there is a higher risk of hypoxia. Some patients with severe lung disease should not travel to high altitude. Some patients may require supplemental oxygen, and extra precautions are required for travel to remote locations. High-altitude simulation tests can be used to assess gas exchange at simulated partial pressure of inspired oxygen at selected altitudes. High-altitude simulation tests can assess acute changes in inspired oxygen or in response to it. It assesses O2 saturation and the effect of supplemental oxygen, and it can assess hypoventilation in response to hypoxia. It cannot assess susceptibility to acute mountain sickness, high-altitude pulmonary edema, or high-altitude cerebral edema. In terms of children traveling to altitude, risks often outweigh the benefits of infants going to high altitude. Children under 2 years of age should not sleep at altitudes greater than 2,000 meters, or 6,600 feet. Children 2 to 10 should not sleep at altitudes greater than 3,000 meters, or 9,900 feet. Children greater than 6 who can verbalize symptoms suggesting acute mountain sickness can safely sleep as high as 3,500 meters, which is 11,550 feet. Acute mountain sickness is not different between children and adults. High-altitude populations differ from lowlanders due to the effect of hypoxia on growth and/or genetics. Growth in childhood is delayed but continues longer. Lower minute ventilation at rest and exercise and lower hypoxic ventilatory responses are generally seen. They also have larger lungs and increased diffusing capacity so oxygen transport is more efficient. Chronic mountain sickness. These are a clinical syndrome in natives or lifelong residents above 2,500 meters altitude. There's increased hemoglobin, often greater than 20 grams per deciliter. It improves on descent, returns on ascent to the same altitude. A treatment is bloodletting or respiratory stimulants also help. There's a decreased hypoxic ventilatory response and worse hypoxia during sleep. Altitude pulmonary hypertension is mild or moderate pulmonary hypertension, and they may not have symptoms. So electrocardiogram, echocardiogram indicate pulmonary hypertension. Symptoms are only with right heart failure. Treatment is descent is preferred, if not possible, nifedipine or sildenafil, and it's distinguished from chronic mountain sickness because it does not have erythrocytosis. All right, so we are at the end of the great adventure, pediatric pulmonary physiology. So we've talked about gas exchange, and we've talked about how ventilation perfusion relationship determines alveolar oxygen and CO2. But since there's no impediment to diffusion of oxygen and CO2 across the alveolar capillary membrane, this also determines blood gases. The distribution of ventilation within the lung is determined by only two things: decreased distensibility or airway obstruction. And these pulmonary mechanics aspects basically modify distribution of ventilation in the lungs and modify gas exchange. We talked about the respiratory balance. The respiratory system is not just the lungs, but ventilatory muscle power and central drive need to be adequate to overcome the respiratory load. So in normal individuals, the balance is positioned in this direction. If respiratory load increases significantly, and or you have decreased ventilatory muscle power or decreased central drive, the balance can be precariously positioned or perhaps positioned in this direction, which is inadequate ventilation or respiratory failure. And we discussed ventilatory muscle function and control of breathing. Exercise puts extra demands on the cardiorespiratory system to deliver increased oxygen to exercising muscle, and we reviewed changes that happen to adapt to exercise, including increased ventilation, increased cardiac output, some changes in peripheral and pulmonary circulation, and changes in oxidative enzymes within mitochondria. We talked about high altitude, and the most extreme example here, Mount Everest, where total barometric pressure is only about a third what it is at sea level. This means that the P inspired O2 and the P alveolar O2 are significantly lower than at sea level. P arterial O2 is significantly lower. PCO2 is also lower. That is, subjects hyperventilate in order to increase PO2 as much as possible, increase pH, and increase O2 saturation, not only by increasing the PO2, but also by shifting the oxyhemoglobin dissociation curve to the left. So I hope you've enjoyed the great adventure, pediatric pulmonary physiology. I've tried to illustrate the basic principles with research studies, some performed by our own group and others. These basic principles of gas exchange, pulmonary mechanics, ventilatory muscle function, control of breathing, exercise, and high altitude will be useful in the diagnosis and management of your patients. And again, to quote Ralph Waldo Emerson, to know even one life has breathed easier because you've lived, that is to have succeeded. And we hope that people are able to breathe better and enjoy life because they can breathe better. Thank you again to our producer director, Dr. Catherine Lewinter, and thank you all for joining me for this, the great adventure, pediatric pulmonary physiology.